Marie McPherson, and I'm the director of the Center for Behavioral Health Improvement and Solution at the University of South Florida. We are very pleased today to have two expert pediatricians with a long course of practice who are going to give us a lot of counsel and help us about transitioning children in general, but especially those with behavioral health issue. So let me introduce our first speaker, and I'm going to go with the alphabet. Dr. Cheas, Rafael Cheas, is a board-certified pediatrician by the American Academy of Pediatrics and graduated from medical school in his native country, Dominican Republic. He completed his internship and residencies at Jersey Shore University Medical Center in Neptune, New Jersey. This is a major teaching hospital in New Jersey. During this time, he has also served as interim chief resident. Dr. Cheas has been in practice since 1994. He's a very active member of the American Academy of Pediatrics, Florida Medical Association, Lake Sumter Medical Society, and vice chairman of pediatrics at Leesburg Regional Hospital. He speaks fluent Spanish and a French aficionado. So Dr. Liz has resided in Lake County with his family. Okay, so now we have also, we're very, very pleased to introduce and have today part of this discussion, Dr. Lisa Gwynn, Associate Professor of Clinical Pediatrics and Public Health Sciences at the University of Miami Miller School of Medicine, and serves as the section chief of community pediatrics, where she oversees 3 pediatric practices. Busy lady, Dr. Gwynn. She's also the medical director for Pediatric Mobile Clinic, a program that provides medical and behavioral health service to uninsured immigrant children. She's program director for the school health initiative, 9 pediatric clinics in Miami-Dade County. Do you ever sleep? Public school and a mobile community immunization program, Shots to Go, which travel to school and health fair to provide vaccination to children in need. Her area of expertise include community pediatrics, school and immigrant health advocacy, an innovative healthcare delivery model in underserved population. Dr. Gwynn is board certified in pediatric, a fellow of the American Academy of Pediatrics, and immediate past president of the Florida chapter of AAP. She is also a member of the AP Committee on State Government Affairs. Dr. Gwynn remains steadfast in serving her community and is a passionate advocate for kids, especially those children who are most marginalized in our society. So thank you very much to both of you for your expertise and dedication to children with special needs. So now the conversation today is going to be how to best to transition children who are going to leave a pediatric environment and then now going to progress to an adult environment, which is very different. It's going to be, they're leaving a very family-oriented practice environment where parental involvement in making decisions to an autonomous healthcare system, adult care, requiring them to make decisions. So this transition of care is especially can be a bit anxiety producing in children who do not have any special healthcare needs, such as behavioral health condition, but it can be especially difficult for children with behavioral health issue, how to do this transition of care from child to an adult. So please, Dr. Gwynn, would you like to present to us what is your practice? What do you suggest to pediatricians trying to initiate this transition of care for children with this type of special need?
So, I think one of the challenges is that this is not really necessarily on our radar like it should be in the pediatrics practice. In my experience, we hang on to our patients as long as we can, And it's this love relationship that we've had with these families from when they're born all the way through. But I think that the transition should really be something that is discussed early on, starting as early as 12 years of age. And this is not just for behavioral health issues, but this is also can apply to any child that has complex health conditions as well. It's the same situation. So, number one, as a pediatrician, having the right transition protocol, if you will, where it's actually formally laid out, almost like a checklist, if you will, where the practice is clear of what the transition policy is. We educate the parents early on. The child is also engaged in the process, so that as time goes on and those visits happen each year, you have a discussion and a touch point each time to make sure that you're on track to have a transition in place, so that when they do turn 18 and they're adults, that you're ready to go. So as a kind of a global view, that's kind of where I see us starting with this conversation.
Excellent. How about you, Dr. Cheas? How do you sort of view this transition?
Well, for me as a general pediatrician, I'm more in the practical aspect of it. We know that we face a lot of obstacle. We know that mental health per se is underserved and underevaluated and appreciated sometimes. So in my practice, what I try to do, I did that empirically, honestly. I actually, um, I think that I came across with more information recently about that because it's being more seasoned in our profession. But I normally what I do is that I usually start probably not so early about 12, but I do believe that the idea is great to start at 12, to start with just a conversation, perhaps a consultation with the parents, just talking about their situation and what their needs might be in the future. In my practice, I usually start probably about 16 because they tend to fade out about 18 when they just finish high school. And then what I try to do is I normally try to team up and try to identify in the community doctors or other colleagues who feel comfortable with the idea of those particular pathology or conditions. And then I usually do through meeting in the society or when we go to the medical staff meeting, and I see the level of comfort and competence, and then I will start talking to the patient first and the parents about that transition, how that can be accomplished. So in summary, I try to identify people who are going to support that, and they're going to be able to carry on that type of care, in particular when it comes to mental health, all the care, but mainly children who has been diagnosed with certain conditions like ADHD, depression, or anxiety, etc.
What about you, Dr. Gwynn? That's that's an excellent summary, Dr. Chase. I think what we're trying to figure out, to look at what are some of the barriers to that transition of care, especially for those children with special needs, and how can we sort of smooth the way? And as you just briefly touched on, Dr. Chase, that you try to identify a sympathetic provider in the community. But how difficult is that? Is that one of the barriers?
Yeah, for sure, it's a barrier. And the other challenge is insurance. So you might have the perfect person that can take over care, but they're not on the insurance plan of the family's, insurance. So there's insurance issues. There's also legal issues. Is that child going to be able to take care of themselves when they're 18? Parents lose all rights when the child turns 18. So, I mean, as a parent, that happened to me. My daughter was seeing a mental health professional, and suddenly I could no longer make appointments for her. I couldn't talk to the doctor. I was in the dark. And so, having those conversations early on in terms of how functional can that child be when they're an adult, and whether you need to have some legal considerations for guardianship and so forth once they turn 18. So again, having those conversations early on is really key. But again, unfortunately, it's access and insurance coverage, and finding enough providers in the community that have that level of comfort. And so there's the medical providers, but then there's also the psychology side of this as well, the counseling side. Hopefully they're with a counselor or mental health professional that can see them through adulthood, and that isn't so much an issue. But it's really the physicians that where I see the biggest barrier, once they turn 18 and they're over on the adult side.
That's very true.
Very true. You would agree with that, Dr. Cheas?
100%. I mean, we have that limitation, that barrier, with insurance. And the other thing that I would like to say too is that one of the limitations that we have in primary care, as you know, especially we're in private practice, we do our best, but the reimbursement could be an issue. It's like you cannot feed those patients, let's say, or a consultation or counseling on, let's say, transitional care. I don't know if there is a code for that, but I think it should. And the academy should try to advocate for that. So, because it's something that, it takes about a good hour. I mean, especially like for me being a male, I have to have a chaperone in the office and in the examining room to talk individual with the patient, and then go and regroup and talk to the family and explain those things. So I'm completely agree with that, but I think that we should advocate for some sort of reform also for reimbursement of this type of service, because it's time consuming, but it's worthwhile worthy to do it.
And the other thing too is once say you do have a successful, connection with an adult provider, the conversation doesn't end there. Ideally, and again, as part of your transition protocol, you should be following up with that provider to make sure that there was a smooth transition. And if you could be of support, that's in an ideal world, but you're not compensated for that interdisciplinary, time either. So it is very time consuming for physicians and staff. The other thing I wanted to bring up too is medications, especially prescribed medications, and what is probably one of the most challenging medications is ADHD meds, because there's a lot of providers out there that are not comfortable prescribing stimulant medications to adults. So that's another barrier that I just wanted to bring up, making sure that those medications that the patient is on can be appropriately prescribed, on once they've transitioned to the adult side. A lot of my patients, what I've ended up doing is having a psychiatrist, start to have them transition to a psychiatrist, that can manage the medications, if there aren't sufficient just regular docs that are willing to do that.
So who do you find is the most difficult to convince to sort of let go, the parents or the child? The parents, Cocoon's been used to really organize the care of a child, and all of a sudden there must be anxiety on the parents' side as well. Do you find that to be true, or?
Yeah, no, I'm agree with you. I think that for me, the children are the one who have a hard time to let go. Because I try to develop that connection and relationship. As a matter of fact, I sometimes, they go to college and they actually get into that conflict that they don't want to let go of their pediatrician. It's like, can I still come over here? And they love that lollipop, So, so I know when they're making the transition too, because I know when we offer the lollipop, they say, no, thank you. But that's usually around 16. But no, but that's, and it's true. But normally for me, believe it or not, the children, they actually get a little confused, or they don't want to let go of the place that they've been taken care of. But I agree with you too. Getting a psychiatrist sometimes it is, and I do that, when I find myself against the wall that I don't have a provider, either because of insurance or the lack of confidence or training to care for the child with that, or the adult with that with the diagnosis, we had to resort to the psychiatrist, and we know that we're very pressed with that too, with psychiatry. Although now,
Yes.
thanks God, we have
Yeah.
you guys as a support, but to get a psychiatrist, and then there is a lot of issue with the functioning of those offices and even the personality issue, and people. It's a big problem that we face. It's a big, but overall, in my practice, I think that I've been managed to. I have opened myself to even treat children or adults or children who are becoming adult in the transition that up to 26 years of age. I have some of them that I take the risk. I make it sign a waiver that say, I really, my insurance only cover until here, or I tell them verbally, and I take the risk because I don't want to live and, abandon them over there,
So you're saying that those children are sort of a 26 range, do not mind sitting in a pediatric office with toddlers and
Yeah, that is a problem that we face, and I have thought about that. But yeah, I think when they are so attached to you, especially that particular group, they really don't mind,
Yeah, I think there's room for expansion of that. We use telehealth quite a bit for mental health visits in primary care, especially for medication checks and so forth. So that is something that might be a little bit more palatable for 26-year-olds is to have a telehealth visit. But again, we have challenges with telehealth and reimbursement as well. So I mean, it's right now we're okay with parity, but in the near future, we may not be able to bill for our services through telehealth like we have been since the public health emergency. But I also wanted to bring up something that's very important. You mentioned, Dr. Cheas, about kids that go off to college. That's a big challenge when kids who have behavioral mental health issues and they go off to college, they're pretty much cut off from the support that they get back at home. So it's important before they go to school, especially if they go away to college, to look into what programs they have and what support services the university that the child is attending, what support services are in place, and get that ahead of time, including making sure that the child has appropriate accommodations within the classroom. And also medication wise, can you continue? A lot of pediatricians who prescribe ADHD meds will continue to prescribe them and, just see the child through telehealth for med checks to make sure that everything is going well. But it's a challenge because stimulant medication, some pediatricians will transition college-aged kids to short-acting stimulants because of their crazy, study schedules, and they're up half the night and all of that. And we find that sometimes the meds can be misused. So, some pediatricians have a real concern about even continuing to be the prescriber of stimulant medications because of the risk of, it get either the child or the young adult not taking the medications properly, or sometimes it even ends up getting shared with friends and so forth. And it's a real problem on college campuses, actually, the over and misuse of stimulant medications. So it gets complicated when they go off to college and they are on these medications that are serious, that need close monitoring, and to make sure that these students get the support that they need.
Right. I mean, that could be a difficult conversation too. I mean, they're off to college, and it's just a mere idea of finding, within maybe the university or the college system, to have that continuity of care, and that medication can be refilled sort of, easily, without too much lapse in between where a patient could deteriorate, I assume. Wouldn't you say?
Yeah. Now, you guys in the academic setting, I know you're in the academic setting. Do you have already in different programs or at the university level? Do you have like a already identified those patients or those children who might need the help, or they have certain diagnosis? And I don't know if that gets screened. Does it get screened? Because normally what I get the form. I get a form. Oh, I need a 504 or IEP, and I'm going to college, and I'm gonna need some sort of documentation of that. Not all the time, because that's another thing. I mean, some without diverting. Sometimes one of the things that I like the issue about the transition and the conversation is a lot of people, parents in particular, believe that when they turn 18, they don't have ADHD anymore. It's like
Okay.
they outgrew that.
Or any other mental health condition, whether it's
Yes.
depression, anxiety, whether it's dyslexia, whether it's any condition that a child might have a 504 plan for. Some colleges, to get them connected into the psychology or the office of they call it different things at different schools.
Yes.
But to get them into those programs, sometimes they need to have documentation, the formal evaluation for they can't the parent just can't request it. So that takes time. And so, and if they get accepted, I don't know if they get accepted. I forgot when the time is to get accepted, in the spring, I guess.
Yes.
You don't
let's
have
bring-
that much time to get to get it all together. So in academics, we have regular primary care practices that function. I was in private practice for 9 years, so in academics we have similar. Our clinics function in the same way as out in the community. I mean, so we certainly have the same issues as those private practices. But yeah.
Actually, you both identify a very important issue for those children going to college, to have a plan. So to identify those children, in your practices or any other pediatrician practice which is college age, is this really a conversation to have with them prior to, now you're going off to college now, this is what you need to be aware of in order to maintain continuity with your medication. So I think that's a very important issue right now because, as we all know, that the first year of college can be very disruptive and tumultuous, in a totally different environment. So I would assume that we should make a note of that that's a very important issue to tackle with the young adults, leaving the home environment and your practice cocoon sort of environment and getting into adulthood. So going off to college, I think that's something that perhaps, Sabrina, we should make a note of that. That's an important issue to identify with that particular
Absolutely.
Yeah, and knowing that a lot of mental health conditions emerge when they're teenagers. So, sometimes they're 16, 17 years old and you're just figuring out that they have underlying issues. And it takes time to figure out what the diagnosis is, what the medication is. And so sometimes they're not ready. They're not ready to go. And we have such a mindset of, okay, they graduate high school, they go to college. And some kids, they're not ready, from the medical mental health perspective. But they have this pressure of, okay, I got accepted into this university and I'm going. And, it can be very, very worrisome to parents. If things aren't completely in line, if things aren't totally stable and taken care of. And look at all the pressures that kids are under once they get to college and they're on their own for the first time, and there's a parent not there to remind them of that they're taking their medication, or they don't want their friends to know they're taking medication, or going to the support center, or, getting special accommodations in the classroom, So I think college age is probably the hardest time for these kids.
So would you say that, that's a particular important challenge to have a conversation with parents, kids going off to college. It can, because as you said, it could become a very critical and important issue if they decompensate in their new environment. So I think, so we definitely think that this is from what I heard you say, that paying particular attention to this population migrating from high school to college, especially those children with behavioral health issues, in terms of follow-up, medication, finding who in the new university or college environment is going to be the support group. So I think, you've identified a very important subgroup of patients for us. One other question that I had, so when the child transition, do you also transition all of their medical history and notes to the new provider, to the new adult providers?
Yeah, for me, they request the records. And in my record, I actually, I don't know if everybody does that. I have a different electronic medical record, but before I did it, I have a problem list. So I try to, because it's hard to go, you're in a busy practice, but I try to provide in a problem list all the more, well, everything for the reason that they can, especially for sick visit or any condition. So it's kind of listed in order. So, and then if the doctor will want to elaborate, I will talk to them if they want to elaborate any one of those diagnoses that I had, particularly in that one. But I will have like a chronological event to answer your question about that. That's what I do in the practice. And so far it's working for me. I have never got anybody who, called me for or coming frequently for any other concern in that regards. And but I'm also open usually to talk to. My instruction in here is usually any doctor who call, pull me out of the room because I know they need to speak to me. So
Yes.
in that way, there is not like a missing call because we all get busy. But to answer your question, yes, in my medical record, I know Dr. Gwynn, but that's what I do. I try to list that so it make it very apparent to them what's been going on.
That's
Yeah.
very good advice. Would you agree with that, Dr. Gwynn?
Yes, I agree
Yes.
with that. At minimum, having documentation from the electronic health record with an overview of their history, and leaving the door open to have conversation. In a perfect world, you want to have a warm handoff, but that isn't always possible. But yes, I agree.
Yes. So just another question that I had, and I think it's pretty well accepted these days, but have you found that both parents and the young adult child are very amenable to telehealth? Or do they prefer to come and see you in person in your office?
In my experience, teens and young adults love telehealth. The last thing they want to have to do is sit in a doctor's office. And I think for parents, it's more convenient. I don't know, Dr. Cheas, if you have the same experience, but
yeah, I've been seeing more and more, especially with the younger generation, since they're so used to the computer and all that. I still struggle myself with a little bit of that personal touch. I don't know if I am from the old generation, that you need that one-on-one. But to answer your question, I feel that they feel comfortable, especially those children who are issue with anxiety. Those children who has a comorbid, especially anxiety, OCD, they feel more comfortable with talking to somebody that they don't see, personally. And their service has been great. I've been getting, the only problem that I have is like what Dr. Gwen say, because of the confidentiality, we are not in the loop. And either if they will leave, transition, or even during the time that you're still taking care of them, it's like, okay, what do you talk to and sometimes they don't have a recollection of what is being told. Particularly when I'm managing medication, I usually like to ask the question like, okay, have you talked about if you're ready to come off of the medicine? Just to get a sense of it.
Yeah.
And that conversation is like, at least the feedback that I get from the patient is like nobody talked to me about that. I say, well, I mean, we have a time limit. That's why we're in the therapy. But to answer your question, I think patients now, the new generation, they feel very comfortable with telehealth.
That's good. That's good. And we suspect that it's got, and I think it's probably going to be more and more and increasingly going this way. I mean, for conditions that are follow up, especially, but it's still tough to take a blood pressure or I don't know, to blood draw virtually. Not yet.
Yes.
And sometimes the challenge is when you're taking care of college kids is their time, sometimes you have to connect with them in the evenings or maybe on the weekend, because it can be challenging because of their class schedule to nail them down to get an appointment, for them. So you have to kind of be flexible.
And we also have busy social lives.
Yeah.
Yes. So now at this point, I'd like to open up to questions from our attendees. So does anyone has a question? Sabrina, do we have questions?
I actually have a question, Dr. Gwynn. You mentioned that you like to start talking about transition around 12. Do you give the patient or the parent any resources or direct them to online resources?
Not that early.
Mhm.
Usually, we don't really start doing that until they're more like 16 or 17. So, and every patient's different, certainly there are online resources that you can start, and now today with the apps and, whether it's Headspace or Calm, or they have online counseling now that you can do on your phone. There's a lot more out there that could benefit your patient even before they're transitioning. So certainly, if there are opportunities to connect your patients early on with those types of things, they can get used to using those applications so that that's something that they'll have in their armamentarium, if you will, when they are, off on their own. So I usually don't really start with anything specific at 12. We just start to have those conversations. And I have to say it's more with the parents than with the child when they're that young. We usually, I wouldn't suggest, really having conversations with the child included until they're more like 14, 15 years of age. And that's always, see, again, that's assuming that they've got a solid diagnosis that young. A lot of the diagnoses of mental health conditions don't necessarily happen, at that early of an age. Sometimes it's during their teenage years where these things kind of come forward and come to the surface. So
Very true.
I actually did have a question. When you're seeing kids going off to college and they're on stimulant medication, you sometimes find that the student health centers are unwilling to provide that medication at all, or is that an issue?
yes, it is.
And that was
So we usually have, prescribe a 90-day supply, we do workarounds, mail order prescribing is helpful, but, it depends on the insurance company. It depends on the medication, the copay. There's just so many different things. But yes, you're right. A lot of times, and there's a gazillion ADHD medications out there now. So,
and I know that was the main thing being like, it's been years since I've been in college, but transitioning that care, they had no problem with a lot of the psych meds. But as soon as you start mentioning ADHD meds, that's the one thing they didn't do. So now you're struggling to see, okay, can I still get a prescription from my original doctor, or do I have to find somebody that's local to this area and that takes my insurance? And there was just a lot of hurdles to go over. So I just didn't know if that was still an issue or if it got easier.
No. It's still a big challenge, And that's why a lot of pediatricians hang on to their ADHD patients because of that reason. Because if they go off the medications, then that's a recipe for disaster.
Right. Especially like you're talking about the first year of college and being on their own for the first time, and that's you're breaking up that routine. that's not gonna end well if you suddenly end a medication like that. So I was just curious.
Yeah.
We have other questions, Sabrina, I see. Sabrina?
I don't see any questions.
I think Dr. Desiraju had a question.
Oh, I can't see that. Let's see.
Says,
Do you want to
what's the
come off mute, Dr. Desiraju?
Sure. Hi. Hi, everyone.
Hi.
So I wondered, I've never prescribed Qelbree, but I wondered what would be a situation to prescribe it, and what should I educate the families, and when should I actually think of prescribing it?
Which medication?
Qelbree,
I don't know what that is.
Yeah,
the non-stimulant.
It's a non-stimulant, also approved ADHD medication. It's actually initially, as you know, it was used more probably as an antidepressant in that line. So for me, I have experience with that, very good experience with it. So when I see children with attention deficit and also with a profile that fit or a diagnosis for anxiety or depression, just like a Strattera, it just applied to those patients. So I actually have a kid and an adult, and he actually attending, I think, USF, and he has autism and pretty much had come through, very well from the autism, but he also have ADHD. I lost it at some point, and I never knew because mom also has ADHD. So it was very hard to track, the benefit. But one thing that he mentioned, he's going to college, he's working to all these challenges, and he was very concerned because he could not concentrate. But at the same time, when he was in the stimulant, he was having a lot of issue with not feeling himself. Well, he never expressed that to me. And I say, oh, I heard about this one. Strattera, some people kind of feel a little shy away because people Google a lot and they start reading about the liver effect or toxicity, hepatotoxicity that could be. So I said, well, let me try this. And I usually approach with that, seeing the anxiety, this is a new medication. And I'm telling you, I had 3 patients on, and it has been wonderful. So
I think and I think it's on a patient by patient basis. What I would say that I wouldn't start anything new right before they're going to college. I would do that a good year in advance to get, or at least 6 months in advance, to get them to make sure that they're going to respond to the medication, that everything is stabilized and everyone's comfortable with the medicine, because we don't want to wait till the very end, right when they're getting ready to go off to college, and then you're dealing with trying to manage the medication and they're at long distance, and it just becomes an unfortunate situation. And usually what happens is the kid stops taking the medication. If it's not working, they go off, they'll just stop taking it. They don't have the parent there to say, hey, you need to take your medicine. They stop taking it, and then their school performance drops, and then it's a real problem.
Yeah, very good point. Excellent.
Dr. Desiraju, does it answer your questions?
I'd say yes. Thank you.
Okay. Anyone else, Sabrina?
Are there any other questions? I don't see any in the chat.
Okay, all right. So I think, we've identified some, so this we've identified several issues, to make sure we communicate, we provide some kind of documentation and for the practicing community. One of them was clearly, the insurance and legal issues in transition of care. and also medication management, the continuity of medication management, and especially for those children, young adults rather now, I'm sure they don't want to be called children, those young adults on their way to college. And I think that's an important issue, and that has been identified today, that we really need to be clearly making sure that, we know the patients are just about going to be going to college, let's say in the fall, and all the the issues that they need to be really be aware of to avoid any any unfortunately adverse effect, and that they are on top of everything. Identify what do I do if my medication runs out. How do I identify someone within the college community? How do I, keep in touch with my primary care physician? So those are very, very important issue for a very vulnerable population. So I think at this point, Sabrina, do you have anything else you would like to add?
No, I think that's it. If you think of any questions, feel free to email Adriana or myself. Adriana will be sending a training satisfaction survey that we'll need by close of business next Thursday.
And thank you, Dr. Gwynn, and thank you, Dr. Cheas, as usual, for very informative, really discussion right from the front line. And that's what we need. We just don't always need to read, an article, but really what is happening in the front line. And especially, Dr. Gwynn, you deal a lot with very vulnerable populations. I think, that's probably, as you see right now, you see a lot of immigrant children. I mean, do you see the young adult in that population, the transitioning stage?
We usually try to transition them when they're 21. It's a challenge because we can't vaccinate them past 18 because we're a VFC provider. So we get into that, but we'll see them up to age 21. And I will tell you that uninsured children or underinsured children have the biggest challenges with even finding medication that is reasonably cost. If these medications for ADHD and others can be extremely expensive. So there's a lot of untreated mental health illnesses out there because, they just have lack of resources. So.
Well, another important issue that we've identified is that, a physician should be compensated for the transition of care counseling. And we will look into it to see if there are any codes that can be used to facilitate the discussion for transition of care, and at the same time to get reimbursed for the work you do, because that's a very important time in a young adult's life. So that's also an important issue we've identified today. So, my God, a crop of issues. Okay. So thank you all very, very much. We appreciate